Thank you for having me here today. I really appreciate the opportunity to be here. Since I'm fully immunized and pretty well distanced, I'll go ahead and elect to not wear the mask while I talk at this time. Unfortunately, I've never really been much of a football player. I can barely catch a ball as it is, but for now, and then I also want to thank Dr. Barr for that excellent allegory of stonewashed jeans for 80s mosquitoes. I really like that a lot. I teach a lot of medical students and residents, so I may have to use that in the future. So, what I'll be talking about today, we'll be focusing on what's new in infectious disease pediatrics and an update on pediatric immunizations. There are a lot of nuanced subjects within my field that are new, perhaps, talking about cryptic species and aspergillosis infections in immunocompromised patients, or, new guidelines for resistant gram-negatives in severely ill individuals. But since those are particularly nuanced and usually just within the domain of people treating hospitalized infectious diseases, most of what we're going to be talking about is what is more relevant to the community. And so COVID will be taking up a lion's share of my presentation, but we'll also try to speak a little bit about the respiratory virus surge that's ongoing for the United States as well. And my talk is comprised really of two smaller talks that are supposed to take about 30 minutes each. What I'll do is I'll kind of just go ahead and go through both of those, and then that way we'll sort of have all of our time at the end for any questions or comments. So we'll start off with what's new in infectious disease pediatrics. And the relevant disclosures, of course. So I will be discussing vaccines during this talk that are under emergency use authorization. I'm going to use some brand names for identification purposes, but those do not serve as endorsement of those brands in question. And I don't have any relevant personal financial relationships for any of the drugs or therapies under discussion today. So what I'll focus on a little bit is kind of from our objectives perspective, some of the questions that I get most frequently regarding SARS-CoV-2 in children and adolescents. And so some of these relate to just what do we know about the epidemiology of this infection in these age groups? What are the harms that we actually see in children and adolescents? And then some of the questions I hear a lot from parents of children who are immunocompetent, parents of children who are immunocompromised. Will my child be safe in in-person school, and what should I be doing to make sure that they're protected, or how should I think about sending them to in-person school versus keeping that home for virtual school? And hopefully that will also be helpful for primary care providers as well. Then we'll kind of shift into why are our pediatric inpatient centers full and what's in store potentially for this winter as well. So first of all, we'll talk about what do we know about the epidemiology of SARS-CoV-2 in children. So this is just a quick illustration of where the major hotspots are of SARS-CoV-2 right now in the United States. As you can see, all of the hotspots for infection have now shifted from the American Southeast really up to our region in the American West, Pacific Northwest, and Intermountain regions as well, with the additional hotspots in the Midwest and Northeast and Alaska. So we're definitely right in the thick of the surge or the wave, as you will, for this pandemic at this time. In terms of children, just some of the basic numbers for our U.S. cumulative cases. This is pretty fresh data just from the last week or two from the American Academy of Pediatrics. They publish this data on a weekly basis. They provide a report in case you want to check it out yourself. So we've had close to 6 million total child COVID-19 cases. And at this time, from a cumulative perspective, they comprise about 16% of all cases that we have in the United States. The overall rate, and this is the cumulative rate again, is 7,838 per 100,000 cases. In Utah, our cumulative cases, we've had about coming up on 62,000 cases, and they represent about 12.2% of all COVID cases here in this state right now. And again, overall rate is pretty similar to that we see nationally as well. And this is just an illustration again of basically the same data but broken down by state. California is up there at the top just probably by the sheer number of individuals, followed closely by Florida and so forth. Utah coming down a little bit past the halfway mark down there in terms of cumulative cases. And in terms of the percent cumulative cases that were children by state, again, our overall percent of infections that are in children is 16%, and then Utah falls a little below that at the 12% mark as well. No worries. Okay. And then finally, some of the additional numbers, we can look at the change in cases per week. How much has it increased per week? So just in the past week, so this was data that was published just recently, and I'm sorry if there's feedback going on, just let us know. We've seen about 173,000 additional child COVID-19 cases just in that past week. So those are the additional cases from all states in the United States. And that represents 26% of all cases in the past week as well. So while the overall cumulative rate is down to about 16%, the actual change in the number of children who are having, or the new cases, children represent a little over a quarter of all the new cases that are going on. And what's interesting is you can see this when you actually represent graphically by the number of child COVID-19 cases added in the past week. So I think most of the people in this room will be familiar with these graphs demonstrating the different waves, which had a major hump in the winter of 2020-2021, and then our wave that we're in the midst of right now being much smaller. If we look at the graph as it pertains just to children, we see actually the wave that we're in right now is actually a far greater wave than the one that was in the winter of 2020-2021. Again, illustrating the same concept I'm getting at, that this wave is really a wave that's hitting children far more severely than last year's waves essentially did as well. And then finally, we can also look at the breakdown by children and adolescents by their age group as well. So this is, again, from the Centers for Disease Control and Prevention. The overall rate there is the solid blue line, but then our adolescents are represented by that dashed blue line, the 12 to 17-year age group. The dotted line is the 5 to 11-year age group, or what I always refer to as just kind of elementary school children age. And then finally, the toddlers and preschoolers at the 0 to 4 age group, kind of more mirroring the adolescent age group. And what this is getting at is that the cases that we see that are most symptomatic, or at least getting tested the most, or perhaps who are contracting it the most, it's a little difficult to tease out that information, is in children and adolescents, we see a bimodal age distribution. It seems to be the infants and the preschoolers are catching it the most alongside the adolescents and teenagers. Those school-age children in between, the elementary school kids, still do catch it, but they seem to be at a lower frequency than these two other age groups. They seem to represent the lion's share of all of these cases that we're seeing in this current wave in the United States. Now, when we talk about the burden of disease, kind of what a lot of people want to know or want to talk about is what's the mortality, what are the total number of deaths, for age groups that we're talking about. And obviously, we've had a pretty substantial burden of disease in the adult age groups and certainly the older age groups. 700,000 is the figure that we're using right now for the number of deaths that are known from COVID-19. But in terms of pediatric deaths, what is surprising is that it's only about 497 that we have so far, this far into the pandemic, about a year and a half. And now every single one of those deaths represents an unimaginable tragedy for the families and the providers who have had to be there for those. But at the same time, a lot of people have seen this as relatively good news, that our pediatric and adolescent populations are not as severely affected by such a terrible outcome in this pandemic. And so that can kind of transition us into what are the harms of SARS-CoV-2 infections in children or COVID-19 infections in children. And when people hear that relatively low or that very low mortality rate in children and adolescents, the takeaway a lot of them have is, well, then COVID-19 just isn't that bad for kids, right? It's not a big deal if they catch it, not a big deal if they perhaps don't take a lot of preventive measures when they're in school. But my response to that is, no, honestly, COVID-19 is still both directly and indirectly very harmful to children and their families. And I'll bring up just a couple of points here to illustrate why. So the hospitalization rate, which pertains to the actual need for hospital-level supportive care in children and adolescents, is actually double that than we saw in the H1N1 pandemic of 2009, which was the worst flu pandemic most of us have seen in recent memory. It was 51.3 per 100,000 compared to 23.9 per 100,000. And in addition to that, when I'm speaking about these adolescents or 12 to 17-year-olds, about 1 in 4 of the children hospitalized with COVID-19 require intensive care level of support. All of this is a huge burden for families. It's traumatic for children to go through. Hospitalization, even if you survive hospitalization, still comes with numerous comorbidities. I don't think any of us, given the choice, would ever want our child to be electively hospitalized for something that's completely preventable. So this is one of the points that I like to make whenever kind of people are saying, well, COVID-19 just isn't that harmful for kids, it's not that important. We still see plenty of kids get hospitalized with it. Hospitalization comes with increased healthcare costs, increased comorbidities, and of course there are long-term effects for children as well. In addition to that, there's also indirect harms to children and their families. So this was just one illustration here. So this is a study of children published in the New England Journal where it was children in a summer camp outbreak who came home and developed symptoms from COVID-19 and tested positive. And upon returning home, those individuals who transmitted to their families actually transmitted at a 45% secondary attack rate, meaning that's almost half of the individuals in the household are catching COVID-19 from the index case child who came home and brought it home from the summer camp. 10% of those household contacts subsequently required hospitalization themselves. And this is a point that we try to make also, that children are certainly very capable of transmitting the virus to their family members. If they have family members who are unimmunized, family members who are immunocompromised, family members who are older or who have other health conditions, bringing this virus into the household can have very severe harms for the entire family as a whole. And unfortunately, we do see numerous news stories about children who wind up orphaned from one or both parents passing away from COVID-19. So while the children generally have a better outcome in terms of mortality, what they bring home to their parents may have very severe effects for their families and, of course, their psychodevelopment later on because of what happened in this transmission event. Again, this is another illustration of the same concept, but this is actually from very early in the pandemic. This was early in 2020 that we actually conducted this study here in Utah where we demonstrated that children who picked up COVID-19 in child care centers were more than capable of bringing it home and transmitting it to their household contacts as well. So again, just further illustration that this isn't just even teenagers, it can also be young children bringing home the virus and transmitting it to vulnerable individuals in the household. So a lot of questions that I have received when I'm taking care of children with HIV, children who are transplant recipients, immunocompromised, and also immunocompetent children as well, is in-person school safe? And I hope this will be useful information, for those of us who are trying to answer this question for our families that we take care of. So, like all good infectious disease doctors, my answer is it depends. And it comes down to multiple different factors that we want to take into account when we're trying to answer this question. So the first is, what is the actual community transmission rate in the area that we're talking about, where the child will be attending school? What kind of variants are circulating in the population, because that affects transmissibility, and whether the student and the staff, or students and staff, referring to the population in the school as a whole, are vaccinated, which will also hopefully prevent transmission within the school setting. And then finally, what mitigation measures is the school district taking to make sure that they don't transmit the virus from student to student or staff to staff or staff to student? So first of all, this is an illustration from our colleagues in Australia. This was from Victoria, where they would look at the overall cases in the state of Victoria, which is the dark line spiking quite high there. And then they actually also looked at the actual cases transmitted within child care centers and schools. And they found a pretty nice mirroring effect of the cases transmitted in schools to those transmitted within the community. So very blunt, rough kind of provision of data there that gives us an idea that yes, school transmission mimics, albeit at a lower level, community transmission. This is a study from our colleagues in the United Kingdom, where they actually were able to create a line of best fit and look at, there's an association with the regional incidence per 100,000 of COVID-19 cases in the community, and they could actually look at the number of confirmed outbreaks in school settings and found that it predictably rose with the increased community transmission as well. So just further illustration that school transmission is not immune to what's going on in the community, and children and teenagers are again very capable of spreading it amongst themselves, or staff spreading it to students, staff spreading it to staff, and so forth. And finally, just an illustration from here in the United States where we look at the moving average percentage of community SARS-CoV-2 positive test results, and then of course those that are associated with child care facilities. And we generally see, while there are some outbreaks that are outliers with large numbers, even though the community transmission was going down, overall the fit is as community transmission goes up, the outbreaks in daycare centers and child care centers seems to go up as well. So to kind of give you some guidance in terms of answering families, is it safe for my child to return to school, or what should I be worried about? You can point to, well, what is the actual community transmission rate, here in the county that we live in, or here in the state that we live in, and kind of help walk the family through their risk-benefit kind of calculus in terms of whether they feel safe for their child to return to in-person school. This is just a quick point about the variants in circulation. We don't need to belabor the subject of the Delta variants versus previous variants versus the potential, transmissibility of the Mu variant. But essentially, as we see new variants of SARS-CoV-2 come along, we see that there's going to be differences in the transmissibility of each variant. And when there is a new variant that becomes predominant in a population or predominant in the wave of the pandemic, we need to take into account how transmissible is that variant. So the Delta variant, we do know, is more transmissible than the previous variants. A number that a lot of us have become more familiar with over time is what's called the basic reproduction number, or the R0 value in infectious disease epidemiology. And just speaking really simply, it's a number of new cases that can come from one new index case. So for example, for rhinovirus, for the common cold, the R0 value is typically 1.2 to 1.8. That's the average number of people who will catch a cold from one index case who are also vulnerable, in the same setting. Measles is, again, one of the most infectious diseases in the history of the world, so it has the highest R0 value known for any infectious disease, 12 to 18 in most studies, but in certain community outbreaks, in certain settings, it's been recorded as high as 30-something to even 60-something as well. Ebola, for all the danger and worry associated with it, has an R0 value of 1.5. The original lineage of SARS-CoV-2 had about 1.8 to 3.6 with a mean of 2.8. But with the current Delta variant, we're seeing numbers anywhere from 5 to 9 cases from one index case. So when the family asks you, is it safe at this time, or what should I be worried about at this time with my child returning to in-person school or going to events and things like that, you want to take into account, is a variant like the Delta variant predominant right now? Are there future variants that we may need to be dealing with in the future? I know there's quite a bit of speculation on the part of evolutionary biologists about the next variants that could come into circulation. But one of my favorite quotes that I heard actually from a podcast from an evolutionary biologist was that evolutionary biology fundamentally is just, it's always looking at things in retrospect. So you can never really predict what's going to take over in terms of, success of a variant in a population or so forth. So there's no way to guess what's going to happen in the future, but you do want to take into account what you know is happening right now in the community or in the state. Vaccination has been spoken of numerous times. It has numerous benefits. We do know that it's protective for individuals against SARS-CoV-2. This is just one illustration. Again, this was looking at children and adolescents who were hospitalized with SARS-CoV-2, and we can see that states with low rates of vaccination had 4 times the rate of hospitalization of these age groups compared to states with high levels of vaccination. Pretty simple math to illustrate that fact. The more immunization you have in your community, in your school, among the children who attend, or the adolescents who attend the school and the staff who attend the school, the lower the risk is for your adolescents and children to attend in-person school. This is a similar illustration, just basically, since the rise of the Delta variant, we see that unvaccinated adolescents have a 10 times likelihood or a 10 times higher chance of winding up hospitalized compared to the non-vaccinated. Or sorry, to the vaccinated, sorry. The unvaccinated have a 10 times chance of hospitalization than the fully vaccinated. Finally, mitigation measures. These are just basically studies where we looked at children in Utah trying to figure out what were factors associated with transmission in schools. And generally speaking, what was discovered was more masking and social distancing generally reduced transmission during contact studies between infected school children to prevent transmission within the school setting. Now, all that being said, I don't think any pediatrician would ever deny that in-person school has so many benefits for children and adolescents of all ages. It's really important to get our kids into school and have them in that social setting, not just for education's sake, but also, as we've seen, for school nutrition, for the provision of breakfasts and lunches, for their ability to participate in after-school events and activities. And overall, vaccination is still probably our most important public health tool for guaranteeing that staff and families and students can all return to school safely as well. Mitigation measures are important adjuncts, but they're not the only measure. And again, vaccination is probably our best tool for ensuring that children can return to school safely. Now we're going to shift gears a little bit, and we're going to ask the question, why are our pediatric inpatient centers full? So when we closed and provided all these mitigation measures over the 2020, over the year of 2020, what we did was we suppressed the transmission of a lot of other respiratory viruses, including influenza, but also RSV, rhinovirus, and so forth. What this did was, rather than stopping the transmission entirely of these infections, is it just simply delayed their typical winter surge, what we in pediatrics would refer to as the respiratory season, into an entirely new season, which was somewhat unexpected. So this is just a graph demonstrating the number of positive RSV PCRs from one recent study, and it gives you kind of a year-by-year breakdown. You see the wave of RSV positive PCRs coming in with basically each winter fairly predictably, and then when we hit the 2020 year, which is represented there in that box, we just completely missed the wave of RSV entirely. So we didn't have any positives, and then all of a sudden there's a surge happening well after that box, meaning that we're getting this out-of-season kind of surge of respiratory virus, or of RSV. And again, when we look at germ watch data from Intermountain, we can see a very similar phenomenon going on. So the grayed out lines represent prior seasons of RSV, and then the solid blue line was this season, just prior to this month of October. So massive surge, completely out of season, and somewhat kind of hitting the system right around the same time as our own COVID surge as well. And in addition to that, it's not just positive PCRs for RSV and other respiratory virus. It's overall the diagnosis of bronchiolitis, which is really filling up our community inpatient centers for pediatrics. So again, this is looking at inpatient bronchiolitis encounters and hospitalizations, and we have a fairly predictable wave for each of those, for each of the respiratory seasons, and all of a sudden just a big long gap, and now a new wave that's coming up as well, kind of out of season. So while this has definitely kind of added a lot of burden of hospitalizations to our pediatric inpatient centers, it's also changed the way we practice medicine as well. So if you are a provider's office that provides palivizumab or Synagis, the monoclonal antibody that's used for children at risk for severe RSV disease, you may be familiar with this, but we've actually had to change the guidance for Synagis with this respiratory season. So just as a quick rundown for those of you who may not use Synagis, it's a monoclonal antibody we use for premature infants who have chronic lung disease, also individuals with hemodynamically significant acyanotic heart disease, pulmonary hypertension, cystic fibrosis, and so forth. And the idea is by giving this monoclonal antibody, it's a passive immunization to protect them against the severe effects of RSV infection. Normally, it's approved to be given starting sometime around in November, December, based on what epidemiological curves demonstrate for the onset of the disease. We've had to start providing Synagis completely off-season now because of this massive RSV surge. So just another illustration of another change that's had to come into effect because of this unseasonal respiratory virus surge. And again, just kind of the same illustration, but this is just the guidance from the American Academy of Pediatrics stating as such. So again, kind of summarizing what I was saying is that this seasonal respiratory virus surge has led to a consumption of healthcare resources, and what it does is it also takes away some of our resources for working with COVID-19. So our inpatient center at Primary Children's is really bursting at the seams. We've had to double bunk children in the same rooms, cohort them together as much as possible in order to make as much room as possible for new admissions. As an infectious disease provider, while I don't necessarily need to take care of things like bronchiolitis or simple community-acquired pneumonia, which might be secondary to one of these respiratory virus infections, I do see a lot of the complexity that comes from complications, such as empyema, and there's now some suspicion that maybe we're seeing more invasive meningitis. We've had multiple cases of pneumococcal meningitis and potentially meningococcal meningitis as well, which we're trying to tease apart right now, whether that's associated with this surge or not. This is, again, Germ Watch data. This is publicly available if you just Google Germ Watch Utah, and it's showing us that we have really high activity of respiratory syncytial virus there at the top. But what I want to direct your attention to as we walk down through the moderate activity rhinovirus, enterovirus, and low activity parainfluenza, I've also seen a bacterial tracheitis completely off-season from a parainfluenza croup infection. As we continue to walk down, we see adenovirus, the seasonal coronaviruses, and then influenza there at the bottom. So that's indicating to us that influenza is now starting to make its appearance here in Utah, and it's something that we need to make some plans for. So what's in store for this winter? So I can't speak to what SARS-CoV-2 variants are going to show up this winter. That is impossible to prognosticate. I'm certainly hopeful that this wave is the last of the major waves, but nobody really knows what's in store in terms of evolutionary biology, so we'll just have to keep our fingers crossed. But what we can choose to worry about as infectious disease doctors, we're fantastic worriers, we can worry about influenza-like illnesses and influenza as well. So given that we already know that all of our respiratory viruses have seen a delayed surge, Given that we know that it's starting to make its appearance, we're starting to become suspicious that we're going to see potentially a new wave of influenza somewhat off season. Normally our influenza waves come sometime around late December, January, February, sometimes even as far out as March or even April. But we're starting to see these influenza-like illnesses, according to the U.S. Outpatient Influenza-like Illness Surveillance Network, making their appearance. And in addition to that, we do see it actually showing up there on the top of this. This is DermWatch data. Again, we see influenza starting to show up as well here in rising numbers alongside RSV. And so what we're going to talk about when I segue into the next talk on immunizations is what we need to kind of start thinking about and advising our families in terms of not just being concerned about what SARS-CoV-2 is going to do this winter, but also what we need to be concerned about in terms of influenza, because we don't want to forget that as well. So that being said, that kind of covers some of the relevant new things that we see in pediatric infectious diseases. And what I'll do now is I'll segue into pediatric immunizations as they connect to the previous topics. So again, the same disclosures apply. These are under FDA emergency use authorization for the age groups that are in question. I use the brand names purely for identification purposes, but they do not serve as an endorsement, and I don't have any personal financial connection to anything discussed in this talk. So we're going to ask some questions again. First of all, what's the evidence for the efficacy of the immunizations that we have available in adolescents against SARS-CoV-2? And what are some of the adverse reactions we need to be able to talk to families about when they have questions about these? And then something that's been on a lot of people's minds is when are the younger age groups going to be approved to receive the immunizations? I'll give you a quick spoiler. I don't know. And then what are the shortfalls in immunizations that we need to be aware of? And then what do we need to think about when it comes to influenza vaccination? So let's go over the evidence really quick for immunization in adolescents against SARS-CoV-2. Remember, we have 3 vaccines that meet FDA approval or emergency use authorization for SARS-CoV-2 in the United States. And the Pfizer-BioNTech one is the one that we can use in individuals who are age 12 and older. The others are so far really indicated just for those who are 18 and older at this time. Kind of going back, we remember back in May, the FDA expanded the emergency use authorization to include adolescents who are aged 12 to 15 years. Shortly after that, the Advisory Committee on Immunization Practices made their recommendation for the use of that vaccine for individuals 12 to 15, or essentially 12 and up. And then finally, on August 23rd, we had FDA approval for individuals 16 and older, but not yet for those who are under 16. So a lot of the evidence for these approvals was actually based on this randomized, double-blind, placebo-controlled trial, phase 2-3, and it included about 2,200 participants. They were aged 12 to 15. They broke them up into and matched them 1-to-1 to receive vaccine or placebo, and then had a median of 2 months of follow-up for these individuals. And what they found over these 2 months was that they had a 100% efficacy rate in the study population. And moreover, they had a statistical non-inferiority in terms of neutralizing antibody immunogenicity with the vaccine compared to the placebo. Now, you might say to yourself, well, 2 months is not that long of a follow-up period for the transmission or contraction of an infectious disease. But something that should be pointed out is this was being done while the surge was ongoing previously, so there were high rates of community transmission when this trial occurred, when they observed the 100% efficacy rate in the study population. Now, real life will probably bear out that it's not going to be 100% in everybody who gets it, but at least for the time period for the study that was done, it was seen as very efficacious and a good result. But what are the adverse reactions we want to talk about with our families when it comes to counseling them on receiving this immunization, or what do we need to be on the lookout for in families who have just received this immunization? So as with any vaccine, we have local reactions. That's not really any news there. Redness, swelling, and pain at the injection site. Interestingly, occurred a little bit more often with the first dose than with the second dose in these teenagers who received the SARS-CoV-2 Pfizer-BioNTech vaccine. But this isn't really typically spectacular information. Those of us who have received and given vaccines see this kind of thing all the time. In terms of systemic reactions, this was a little bit more interesting. So saw about a 10% rate of fever in those who received the first dose and a 20% in those who received the second dose. Fatigue was one of the biggest symptoms that was experienced by those who received the vaccine, and headache as well. So those were fever, fatigue, headache, and chills were some of the most expected symptoms based off of the study data. And I'm sure those of you who have taken care of teenagers who have received the vaccine have seen similar kind of adverse effects. That being said, they're typically self-limited and they disappear. There is also a little bit of muscle pain and joint pain as well. Vomiting and diarrhea seem to be pretty low in terms of numbers. And I myself haven't had any teenagers provide that information that they had vomiting or diarrhea after the vaccine. But overall, generally self-limited systemic reactions that, while unpleasant, can certainly be dealt with. One of the surprising reactions that was unexpected was the development of lymphadenopathy. So in some teenagers, in the case of the study that actually occurred, they had 7 total cases, 6 in the vaccine group, 1 in the non-vaccine group, who developed lymphadenopathy, typically more in the axillary region, maybe sometimes in the neck, that was usually found about 2 to 4 days after vaccination. Generally pretty mild, pretty non-tender for most individuals, and typically resolved within 10 days. And overall, it's felt that this is a biologically plausible event associated with getting the vaccine in the ipsilateral arm where the lymphadenopathy developed. So while interesting, it doesn't still seem to be a very surprising or concerning adverse event overall. What has been concerning for a lot of individuals is myocarditis, and I should also add to this pericarditis as well. So what we've discovered since the vaccine has become publicly available for this age group is that some individuals, most typically male adolescents, most commonly after the second dose of the Pfizer-BioNTech vaccine, can develop myocarditis or pericarditis, usually within a few days after getting that vaccine dose. The nice thing about this has been that generally most cases are very mild, in some instances actually only requiring NSAID therapy versus actual immunomodulation or IVIG. But we've had a handful of cases at Primary Children's at least, given that we serve the whole Intermountain region. While nobody has the exact epidemiological data yet on how many individuals develop this, the numbers seem to be very, very low. And overall, the outcomes seem to be very, very good. They seem to resolve all of their symptoms and are returned back to normal activity within short time. Oh, looks like, okay. More concerning for a lot of individuals has also been the development of thrombosis. So this was a study from the United Kingdom. They did a self-controlled case series, and they actually took the entire database of immunizations for the entire nation and included all people who received the Pfizer vaccine or the Oxford AstraZeneca vaccine. While this didn't include those 12 to 15, it did include those who were 16 and older. So we get a little bit of data with maybe some extrapolatable results for our age groups in question. And overall, they found that complications like thrombocytopenia, while it certainly did occur, did not happen in very high incidence rate ratios. Venous thromboembolism was very low in terms of incidence rate ratio. Arterial thrombosis, similar to that, especially when compared to actually contracting SARS-CoV-2 infection, which is represented by the purple lines there that you see. But cerebral venous sinus thrombosis was observed and is a potential complication that has to be taken into account. And if there are any symptoms that are concerning for that, needs to be pursued a little bit deeper or with referral to a referral center. Overall, the conclusions of this study were that while there are these complication rates associated with the Pfizer-BioNTech vaccine, as well as the AstraZeneca one, because this is a UK study, the likelihood of complications from SARS-CoV-2 were far worse. And overall, for most individuals, the risk-benefit calculation would probably favor the vaccine, especially also because the numbers of these complications, thrombosis, myocarditis, are so low, we haven't even had a way really yet to calculate epidemiologically, how many per million that we're really observing. But they do seem to be pretty low and probably comparable to most of the other severe complications we see from routine childhood vaccinations in general. So a question that's been on a lot of people's minds are, when are the younger age groups going to potentially be able to receive immunizations against SARS-CoV-2? So what it boils down to is on September 20th, Pfizer announced that they had really good efficacy and safety data for the use of this vaccine in that school age group I was talking about, the 5 to 11-year-olds. And at this time, all I can really say is the FDA is planning on having their advisory committee meeting on October 26th. And after that, the ACIP will probably meet within a week, is what most people believe. And at that time, they can make a judgment about the efficacy and the safety of this vaccine in children 5 to 11 years. So most people are guessing that if we're going to have a good answer to this, it'll be by early November. But at this time, we just don't know. And not being a member of the FDA or the CDC ACIP, I don't really have a backline to what's going on. I've had that question sometimes, which was surprising. Let's shift gears and think about what are our shortfalls in immunizations in the United States. So we've been talking a lot about COVID, but let's not forget that children are very susceptible to lots of other infections, lots of other routine, what used to be routine childhood illnesses. And one that we really want to think about too is measles. So I probably don't need to remind you, you may have seen this in your own practices, but the COVID-19 pandemic has really disrupted normal immunization practices. And we've seen that both in the United States and certainly globally as well. And right now we're thinking that pediatric populations are probably more vulnerable than ever before to the next pandemic or the next epidemic or outbreak of measles, mumps, any other kind of highly infectious disease. What I can say right now is, for example, Nigeria's been dealing with a measles outbreak for several years. And currently they're seeing the highest numbers in individuals who are under age 5. And when that happens, that typically suggests that it's a failure of the local public health authorities to get vaccine out to the communities, or a failure of vaccine uptake. And so we're seeing that not only in Nigeria, but we can guess that lots of other countries, including our own, are probably susceptible to the same event. So we want to be vigilant against things like measles and mumps, especially as we return to in-person school, in-person childcare, and more individuals are congregating and gathering over the holidays. We're kind of in a situation that's ripe for an outbreak of measles or mumps or any of the other infectious diseases. So this is just another illustration of the same concept I was saying here. So this is actually the CDC's data on the percent change in measles, mumps, rubella vaccine doses administered to children. And we see at the beginning of the outbreak last year, March 2020, a huge drop-off, which makes sense given the closures, given the lockdowns that happened, and an attempt to recover going forward, but not really a percent change well above zero, except in a couple little spikes. So a lot of people are thinking we still have a major shortfall, likely of millions of children in the United States in terms of their routine vaccine coverage, not just measles, mumps, rubella, but all the others that come with our routine childhood immunization schedule. In terms of the barriers why children were not getting vaccinated, they are legion. It's not just as simple as we were under lockdown, we didn't want to go to the doctor's office. While that certainly was considered a significant barrier in a lot of doctor's offices in this survey, there were also fewer sports being played, so people were not coming in for their sports clearance physicals, and that was a lost opportunity for vaccination. People were doing virtual school, so they didn't need to have their immunizations up to date for their entry into kindergarten or other grades. There was also some concern about the lack of personal protective equipment in the doctor's office, so it was felt that providers' offices felt that they could not safely administer vaccines. But more than that, there were also some other problems that were financial or logistical in nature. So patients lost health insurance with the lockdowns as they lost their jobs. They lost their employer-provided health insurance. They also had financial concerns related to the loss of employment as well. And so we saw that also as a significant barrier to immunization in communities. Providers' offices also felt that they had lack of adequate reimbursement, logistical methods for doing virtual visits with in-person vaccinations. They lost their clinic staff. So there are numerous reasons why we had this huge shortfall in immunization, not least of which was lockdowns and concern for contraction of SARS-CoV-2 by coming into a pediatrician's or family medicine doctor's office, but also many other financial and logistical reasons as well. So these are just some recommendations from the American Academy of Pediatrics, but just really recommend reaching out to families by phone, by mail, by any means that are accessible to you, by social media to your patients and their families to reassure them it is safe to receive their vaccines, that COVID-19 precautions are in place. They also recommend that you can be creative and you can use novel methods for catching up on vaccines. And one of the examples they provided was some individuals or some offices have used drive-through vaccine clinics for children to try to get them back up to date on all of their routine childhood immunizations. And then finally, we're probably going to be seeing a lot more issues with vaccine hesitancy going forward, especially as there's been a lot of vaccine hesitancy and news about vaccine hesitancy with the new mRNA vaccines. That kind of does open the door a little bit to concern about, well, what about all the other vaccines my child is being recommended? Once you start refusing one vaccine, it becomes easier to start refusing all your other vaccines as well. And so we really want to have very open, frank dialogue with our families about the importance of vaccination. And while data is helpful, it's not necessarily seen as the most helpful way of helping families through this. It's personal relationships. It's working with a physician or a provider that they trust. Sometimes in the infectious disease team, we get referrals for families to come to us about vaccine hesitancy, and we're always happy to help out. But what I try to point out to people is I'm seen as an ivory tower intellectual who's out of touch with the common people, and I just don't get it kind of perspective from families. Even though I have 2 children that I fully immunize myself. But what helps families most with vaccine hesitancy is not being referred to the big university center up on the hill, but rather, working with their provider who they know, who they trust, who has been there, from the newborn age going forward. Those conversations tend to be a lot more meaningful for families, both from what I can say anecdotally and from what the data suggests as well. So finally, what should we know about influenza vaccination for this winter? So I kind of pointed out already that seasonal flu is incoming. And while we think we're going to have an early surge, we're also concerned we're going to have a more severe surge this year than others. There's no crystal ball for truly predicting this kind of thing, and flu sometimes can be pretty tricky to try to predict. But overall, what we know about flu immunity is we know that your prior immunizations and your prior experience with flu on a population level typically affects the severity and the spread of flu going forward. That's why we recommend 2 flu immunizations in children's first flu season over 6 months of age. And it's why we're worried that if fewer people got vaccinated for flu and fewer people actually contracted the flu last year, that it's going to really rip through the population this year. So that's kind of our perspective on the concern for flu this year, and why we really want to be vigilant about trying to talk to families about getting immunized against the flu and using precautions, washing their hands, staying home if they're sick, all of the things that we should always be doing in any respiratory virus season, regardless of COVID, but it's probably even more important this year than it has been before. So not to get into the nitty-gritty details about flu vaccines this year, but all the flu vaccines are going to be quadrivalent. They are selected to protect against the viruses that are predicted to spread this season. That's based not only off of Southern Hemisphere data, but also based off of experience with the change in the epidemiologic predominance of each flu variant through the seasons. And they're also recommending, like I was saying before, trying to use any means you can to reach out to your family. So for example, this is just a social media campaign that the CDC is recommending for providers to use that on your Facebook or your Instagram kind of accounts to help encourage families that flu vaccination is normal and routine. We really want to make sure we have good flu vaccine uptake this year to help protect our population. So with that, those are some of the questions that I wanted to make sure I kind of answer. Some of the questions I hear the most when it comes to what's new in pediatric immunizations. And with that, I think it's time that we can take some questions. Yes, and did we want to use the microphones?
Yes. Go to the microphone, please. One over there, and one over there.
I'm just going to speak up. Can you comment on the extracurricular activities compared to in school?
Yeah, so extracurricular activities, we've seen transmission. It seems to certainly be less when it comes to any kind of outdoor activities. The extracurricular activities that we've seen transmission occur the most, or outbreaks occur the most, typically were indoors. And so I think the example we actually had from Utah was, I believe it was girls volleyball compared to girls or men's outdoor sports like soccer, football, baseball, softball, and those sorts of things. So when it comes to discussing the risk versus benefit, kind of balance with families, I think that's a pertinent one to include. Is the activity going to be indoors? If it's indoors, is it a well-ventilated space? Versus is it outdoors and so forth? That can help them kind of understand, yes, this is something I feel okay with my kids, or no, this is something I don't feel okay with my kids. That's a great question.
Just a quick comment and a couple questions. Having spent 40 years trying to talk people into their immunizations, I can tell you that in our little guy's office, it's not much easier. And I think the biggest problem is that a lot of people that won't be immunized is a faith-based disbelief. And all the science doesn't work, but you've got to be honest with them. I tell them that immunizations have saved more lives than everything else in medicine combined. And in this community, it's a good idea to tell them, check your genealogy, and you'll see that half the people died close to half by the age of 18, and you're over 100 years ago, and that's immunizations. And in that light, I have a couple of questions. First of all, it was 50 per 100,000 hospitalizations were hospitalized. Is that 100,000 people with COVID or 100,000 people in the population?
I think that's looking at with COVID, extrapolating it out, so not saying that it's 100,000, but looking at the rate and then expressing it in typical epidemiologic terms.
So when talking to people, you're trying to talk into immunizing them, you need the total population.
That's a good point, yeah. So the actual total population hospitalization rate for teenagers it's not quite clear, but I think it is extrapolated from that you're looking at doubling the rate essentially compared to H1N1 of hospitalizations is what it boils down to, is if you had to express it in kind of the simplest terms for the layperson.
And I missed it. How many people in the big study that showed that immunization was decreased risk, how many people were in that study?
2,200.
Okay. And then with the hospitalization thing, it's kind of difficult to ferret out. I'm sure you're aware of the Stanford study that showed that only 8% of kids who are hospitalized and test positive for COVID have severe COVID. You know, they have other things. And then recommendations about masks in kids. Obviously, there's disadvantages to masks, with the Bangladesh study showing that cloth masks aren't any good. And I don't know what is going on in Utah, but I know nationally over 90% of kids wear cloth masks. What are your recommendations there?
Yeah, that's a great question. So, I mean, overall, if it's available to use an actual medical surgical type mask, like the one that I have here, and I see a lot of members of the audience have, which they do manufacture pediatric ones. For example, we hand them out to all of our kids as they come into primary children's or into their clinic visits. Failing that, there is a division in the expert opinion, I would say, on what to do next and what kind of masks are sufficient. But if you can't have the best, then something is better than nothing, typically, is the opinion. And so, well, yeah, and so, but then also you've got to compare not just to the one study, but also look at the others that have come out as well. Because well, there was also the Vietnamese study that was cited at the beginning of the pandemic, typically on using masks, at least for healthcare workers who are dealing with influenza-like illnesses, and saw a decrease typically. Yeah, so I mean, you can take that into account, but at least for now, the recommendations from the CDC and experts in the United States are to use something instead of nothing. Generally feeling that the downside of using a cloth mask is relatively manageable compared to what benefit there may or may not be associated with it. But that's a great point. Yeah. Thank you.
I have a question here. The World Health Organization has recently advised that a malaria vaccine in Africa is effective. There is not much information about it. Do you have any information about the malaria vaccine?
Yeah, that's a great question. So the newest malaria vaccine is actually really exciting. It shows something that's estimated up to be almost a 75% efficacy rate. The last malaria vaccine that was seen as the most promising was closer to 50% or lower. At this point, they are now moving on to the next step in terms of trials. So it's not been released for commercial use at this time. It's still in research onto the next phase of study. But it does look really promising, actually, in the near future. Within the next 5 years, we may have a malaria vaccine that's very effective and may actually provide good protection for children and adults against malaria.
What is the age group that they have the experience with?
So their age groups, I believe, they looked at predominantly adults with the last study, and I think they're expanding the newest phase out into pediatric age groups. So.
Could you address natural immunity versus immunized? Since we're seeing a big surge and we'll have more natural immunity, what's your take on that?
Yeah, so it's not as well studied, but generally speaking, it's felt that natural immunity may still leave some room for development of symptomatic COVID-19 disease. So it's still recommended that even after infection, that at least waiting 90 days after the infection, that you do go ahead and still complete a full course of one of the vaccines that are authorized in the United States. There's some speculation, but it remains speculation, that if you get vaccinated after natural immunity, perhaps you're going to be even more immune, but nobody really knows what the rate of things like your systemic reactogenicity, myocarditis, or other complications from the vaccine are going to be if you caught natural disease and then got vaccinated afterwards. So it's kind of an area where there remains a lot of speculation. It is thought that the antibodies are going to wane and that you do remain susceptible going forward from natural disease, but given it's only been a year and a half since this disease really hit our shores, it's just so hard to say with good numbers and good data, how well the naturally infected are going to stand against future waves and future variants compared to the immunized, and vice versa too for the immunized.
Can I ask one quick question too? I thought that I heard that in the UK they are recommending the Pfizer vaccine, just the first dose for adolescent males. Is that true? And I heard that it was because it had a better risk-benefit calculus for the myocarditis.
That I'm going to have to look into for you. I apologize, I don't know that off the top of my head.
One more question. Is there any word about having combination testing for this winter to be able to test for multiple things at the same time?
Oh, you mean like doing a whole respiratory panel for...
Or at least like influenza, RSV,
Oh, like a quadvalent or something like
yeah.
that? No, not right now. I know that we actually... I know that there's several products under development, but I can't speak to kind of where they are in process at this time. It's a good question.
One
Okay.
more. My understanding was the 90 days after infection really was precaution. If someone had had monoclonal antibody therapy, that they were supposed to wait 90 days, and otherwise, you do the vaccine as soon as possible when they're better. Is that incorrect?
Initially it was related to the monoclonal antibody administration, but then they've really changed it to say 90 days after infection anyways. And I don't know if that came from the consideration that you may have natural antibodies that will render the immunization less effective, is kind of where I think some of that thinking was coming from. Okay, and with that, thank you very much. I really appreciate your time.
Don't go yet.
Okay.
Well, before we let him go, I have two questions. You mentioned that there's potentially a concern about increase of meningitis. Is that in patients who have been immunized appropriately against those bacterial pathogens or not? That's the first one. And then unrelated to that, there was early on with the development of the mRNA vaccines a suggestion that in the future we might stack a bunch of pediatric vaccines into an mRNA platform. Is that underway?
That's a good question. So for the meningitis cases, this is a little speculative just based off of our experience at Primary Children's, but we've seen more than we expect, honestly. And we're kind of concerned that it could be related to just horizontal transmission dynamics between people in the community with more respiratory spread as children return to school, but it's not clear yet. So I can't speak to exactly what that's going to be. But as we see more cases, we have reached out across the web of infectious disease physicians to try to see if they've observed similar things in their centers. In general, speaking of pneumococcal and meningococcal disease, those individuals who are vaccinated should be less likely to contract those infections, invasive infections of those. And in the individuals that we did see these infections in, they were immunized for the most part. But recall that the pneumococcal vaccine only covers 13 variants, essentially. So there are plenty of other invasive variants that are out there. It just covers the 13 most invasive based off of historical data. and likewise with the meningitis vaccine, but they were not immunized against that. In terms of using mRNA as a platform for further vaccines, I do know that there's a lot of speculation and development going on. In terms of other routine childhood immunizations, I haven't heard of anything where they're going to go after MMR or Tdap or any of the others, just because generally speaking, for most pharmaceutical companies and most scientific bodies, if you've got something that's been working well, you're not going to seek to replace it per se. But I do know that they are looking into it. They most recently looked into it for HIV, which the success was not really increased at all with that, and they are looking into it for some other infectious diseases as well. So if I understand your question correctly, it's from a first principles kind of consideration, why would just having the synthesis of one protein in your body provide as good or better immunogenicity compared to having the whole virus in your body with the whole complete set of interactions that go on with that? Is that my understanding of the comment? It's It's a fair point, and really it actually goes to the history of all vaccination and immunization. Smallpox, natural disease with smallpox certainly renders individuals immune against future outbreaks, versus using the vaccinia virus. Chickenpox is another relevant example. Just generally speaking, from first principles, is your immunity better from having natural disease versus the protein from a particular vaccine? It likely depends in many cases on the actual protein and the vaccine in question. We also have adjuvants, recall, that we can actually add to vaccines that increase the immunogenicity of the vaccine. That's actually why the malaria vaccine saw increased success, was because of the adjuvant that was used and the fact that they used hepatitis B surface antigens in that vaccine to help generate better immunogenicity than they saw with previous malaria vaccines. But overall, for all immunizations, what it speaks to is, yes, having chickenpox certainly gives you lifelong immunity. Like myself, I was one of the ones who caught it when I was a kid, but it's generally felt that the economic and the health outcomes associated with a lot of natural diseases that we want to immunize against are unacceptable compared to the cost of the immunization in general. Yeah, I would leave it as it depends on the vaccine, certainly, because some have those adjuvants and those protein additions to them that help actually make them more immunogenic, but also that the cost of natural disease can be unacceptable in many situations too. Yes. Yeah, and I can speak to personal experience. My father, 70 years old, extremely healthy, went to the gym 3 times a week, could out-bench press me, maxed out the machines in the gym every time he went, and was a firm disbeliever in the utility of vaccines. He caught natural SARS-CoV-2 infection, went into heart failure, and was sent home on 6 liters per minute of oxygen and can barely walk. I lost one of my med school letter writers in India after he contracted the disease. He was an amazing worker for polio vaccination and later HIV education, which is how I met him. And he was delivering nutrition to families with HIV, children with HIV. In spite of the huge wave that was going on in India at the time, he contracted it and died. So It's certainly possible that you can have good immunogenicity with natural disease, but the costs are tremendous, and there's no way to know who will have a good outcome. There's even plenty of anecdotal stories of individuals over at the U Hospital, marathoners in their early 20s, who are on high-flow oxygen and can barely make it to the bathroom. We don't know who will have a good outcome and who won't, and that's something to remind our families as well. So with that, thank you very much. I really appreciate your time here today.